My jovial greeting to our esteemed guests, Dr. Madhuri Patel, Madam, Secretary General, and Dr. Jai Bhagwan Sharma, Sir, from AIMS, New Delhi, Dr. Abharani Sinha, Madam, Dr. Bharat Prasad, Sir, and all those who have joined lately. Dr. Kumudni Jha, Madam, from Darbhanga, and I guess the esteemed and honorable chairpersons want to give their input to this talk of Dr. Parul Kodawala, sir.
Sorry. Yes, ma'am.
Okay. Your speech on, your presentation on previous, in all cases of difficult cesarean section.
No question.
It's very nice. And in some cases we also do like this. So, very nice lecture. If anyone want to ask some question.
Good morning, sir.
But
it was an excellent talk, but one thing you said that when the uterus is plastered to the sheath, don't dissect the muscle, so then how do you separate it?
No. To prevent that, at the first cesarean, don't dissect. It is not at that point of time. But not to have that situation, if in the first cesarean we do not dissect the muscle, the uterus won't be plastered.
But in the repeat cesarean, if it is plastered, we often see that.
Then we have to dissect. I mean, there is no way out.
Then there'll be recurrence of, there'll be a recurrence again in the raw areas.
Yes. So that is why I said that prevention is better than dealing with it later.
Thank you, sir.
Yes.
Sir, one more question. What is the dose of oxytocin before extracting the baby in high floating aid?
It is our regular oxytocin, IV we give.
Sir, dose, sir.
The way we do it. Sorry, this part I did not touch because it was routine prevention of profile. 10 units of IV bolus. Okay, and I believe that you all are also using carbetocin now. Yes, that is why I said before putting a cut on uterus in a high floating head, you give this, so it brings about a contraction, and then you cut open, so you can, the baby is slightly lower, and when you are trying to deliver, your hand is inside. If it is a relaxed uterus, it will go on expanding. Rather than if it is contracted, the baby will not be pushed up. It will remain there. Otherwise, baby will be pushed up with your hand. Yes, exactly.
Thank you, sir.
Thank you.
What happened in that case when this was given at the time of fundal cesarean section? What they did with placenta?
In the Jose's case, I said no. After delivery of the baby, they dissected the mesh out, placenta also and mesh also, and repaired the rent for a future delivery. I mean, amazing these people are. That even with such a situation, they could think of another pregnancy because perhaps of their religious beliefs, Roman Catholic. Yes, so whenever it is adherent, that part of uterus also goes with placenta.
If the whole of it is if it is a localized adherent placenta, is good. We can just cut the placenta along with the uterus. But if it is a diffuse placental adhesions, I think then it becomes difficult to excise.
That is where your ultrasound will tell you.
Definitely.
If your placenta is more than 2 centimeter away from internal os, then only think of conservatively.
Yes.
If it is covering that part, then you are going to be very close to bladder and trauma to the bladder will happen. In that situation, you may think of even hysterectomy.
Yes, so it must be
but
a localized.
It has to be anterior placenta,
anterior.
adherent placenta doesn't matter, but 2 centimeter of lower segment is required when you can remove segment of uterus and still repair.
Yes, sir. Thank you, sir.
Dr. Parul, it was an excellent oration. This topic is very close to my heart and I learned many more things, so I'll be adding in my presentation. I would like to share my experience as a, full dilatation, cesarean and full dilatation. So I remember one incident. I was a unit head that time in Gynaecological College and my lecturer was doing cesarean section at the full dilatation and I was operating on the other side. And she came and told me that, madam, I completed the cesarean section. And on the table, while doing the vaginal, toilet, patient started pouring. And we immediately explored her vaginally. But we could not see because she was bleeding so heavily. So we again immediately did the reraplotomy. And we found that the lower and the upper part was incision was sutured very well. Okay, and then from lower down, from one edge which was open, that was bleeding. And then we realized that she has sutured anterior and the posterior lips, thinking that this is an uterine incision. And yeah, and the bleeding was so much, it was really scary. And the upper part of the vagina was retracted. This we realized, we sutured it, and patient went home, very well, at the routine post-op day. Yes. So that's why many times we believe that it is better to deliver the uterus and suture it, which I usually do in my practice, and put a, feel the, cervix, either with the artery fossa or finger, with each and every section, so you don't suture anything else. Sometimes posterior wall of the uterus also you can suture. So this is the best way, that you put your finger, even she is fully dilated, put your finger and confirm that you are in the cervical canal, and then you can do. And secondly, most important part is, I was at Kolkata, and Dr. Team, Professor Team, he talked about the impacted fetal head. And as Dr. Parul said, they deliver by bridge. And he said that India has so much of data of Dr. Patwardhan's technique. You should teach us how to deliver this baby in case of impacted fetal head. That is a deep transverse arrest. So this is what a lovely words he put to us, and I think we all are experienced. Only thing, we don't have evidence-based data, for which require many articles to be published. So thank you, Dr. Parul. Thank you, everybody. Excellent discussion and excellent presentation.
Thank you. JB, you wanted to say something?
Madam has already highlighted it. Excellent talk, but all I want that you must publish it, because you're so much good experience. And if Madam accepts in Jogi, that will be great. Otherwise, I offer you a publication in my journal in advance. Thank you. Yeah, but I mean, cesarean section is such a common operation. I think each and every minute step is very crucial, including pass. And every day we deal with them, and we train our junior agent and senior agents also. So this training must pass on to the younger generation.
Very true, because it touches everyone.
Absolutely. Thank you.
No, I am in process of writing a book on cesarean section.
Sir,
Oh, that will be even great. Yeah, that will even be great.
sir, your lecture was extraordinary, and every one of us have learned something. But we want to show this lecture at our medical college, so that our residents and PGA students,
I don't know whether you have recorded or not. If you
they
have,
will
then you
also
can
learn.
share it.
We will show them.
Sure. Okay.
This is in your laptop, no? This is your laptop.
Thank you, sir, for very insightful and informative talk. It was really fascinating. I request chairpersons to felicitate, sir.
चाय कॉफी कुछ मंगा एकदम कॉफी मंगा दो मंगा सर का बैग में क्या है रखे हुए तुम्हारे लिए तो आइए कोई बात नहीं है यदि थोड़े है टच करेगा तो क्या होगा चल रहा है काम चल रहा है 8-10 को हो गया है ठीक हो जाएगा जुलाई
I welcome our guest faculty, Dr. Alka Pandey, madam.
ठीक है सिर्फ दे Well, may we start?
Now it's on. Now it's on. It's on now. It's on.
हाँ ठीक है ठीक है
हाँ जी.
Hello.
नहीं दी वो उसको सीधा करना है. हाँ.
Panelists, please introduce yourselves to the moderators for their convenience.
Well, I think before that, I'd like to say that the moderators of any chairperson, any panel discussion are the most ignorant person. They don't know anything. And when they're asked to conduct a panel discussion, they just throw this and that, itna utna thoda question dal deta hai, and there is nothing in their mind. That is what I feel. I don't know anything. And I put up so many questions, and here are the experts who will be teaching us regarding those things one after another. That is my belief when I stand as a moderator anywhere in the globe. And now with me, Professor Kumudini Jha is there, and we compiled few questions, and you are there to teach us what are the answers of those questions. And these are all very simple questions, and you'll be trying to go from bench to basics. Let me check who are the panelists. Dr. Archana Sinha, are you here? Archana Sinha, okay. Biba Verma, okay. Kavita Burnawal,
She's also not here.
Dr. Vinita Tiwari, Chandan Pasar, Dr. Sahili.
Yes, sir. Yes, sir.
Sahili, yes. Shalini. Dr. Rishi, Jyoti Das, Rashi, okay. Dr. Deepti, Dr. Priya Sinha, Dr. Priya Singh, yeah. Dr. Ujjala, Dr. Singha, and Dr. Archana Kumari. Is there anybody left? Have I missed anyone?
The 3 are absent out of 30. 10 are there.
Okay. Let's start, okay?
Sure.
So actually we'll be discussing from bench to clinic, menopausal transition. What is meant by menopause? Anyone can answer.
So menopause is a retrospective diagnosis, and at least 12 consecutive months if they have passed since the final menstrual period, it can be diagnosed as the menopause. It is primarily and it is there are many endocrinological changes.
I'll
also.
come to that.
Oh, okay, sir.
I have just asked you what is meant by menopause, and you have said that it is the retrospective diagnosis.
Yes, sir. It is a retrospective
And
diagnosis.
there is loss of ovarian function. That's
Yes,
the
sir.
main thing.
Yes, sir.
That's the main thing.
Loss.
Now, what are the factors on which menopause is dependent?
Menopause is genetically determined and it is not dependent on race, ethnicity or age at menarche.
Is there any role of smoking,
Yes, sir. Lifestyle,
lifestyle change,
obesity,
underweight,
Radiotherapy,
thinning,
BMI,
etc.?
socioeconomic status,
certainly.
education level.
But
Organization.
It has been seen that OCP also affects. Yes.
nulliparity is not important, but genetic factor is the most
Genetic
important
most
factor, as you
important.
said.
If mother has
If mother,
menopause
yes.
at early stage, daughter will also follow that.
Yeah.
It has been seen.
Okay.
The age of menopause also depends on that.
Yes.
You can carry on, sir. You carry on.
Well, now what is the menopausal transition?
Sir, menopause transition is a perimenopausal period in that hormonal change will occur and there will be change in the menstrual pattern. There will be irregular menstrual pattern or the delayed, the interval between the menstrual period will be delayed. There will be raised in the hormones of the follicular stimulating hormone will increase. If it's more than 20, there is ovarian insufficiency, and if it is more than 30 or 40, 40 then it is
I have asked you what is menopausal transition. I have not asked you.
It is
Just stick to the question.
So it is the period preceding the menopause, which is characterized by irregularity of menstrual cycle and moderately raise serum follicular
So,
stimulating hormone.
so the terminology of perimenopause has changed, and the newer terminology of menopause transition was adopted as per the stages of reproductive aging workshop. And menopause transition.
Straw 10.
The straw
I'll come
10.
to that. I'll come to that later. I'll come to that. Now, the clinical and other diagnostic points.
sir,
It
clinical
is a change. It is a change from reproductive life to non-reproductive
non-reproductive
life.
life.
That is the main thing. That is the basis. Okay? And now, just
sir,
carry on with clinical other diagnostic
clinical
points.
finding with history of the patient, we will find that there will be change in the menstrual pattern, there will be irregular menstrual pattern or the delayed difference between the two menstrual cycle is delayed, or with subsequent every month she is getting menses, but the amount quantity of the menstruation is decreased and increased interval. Then there will be changes in the hormones level, there will be increase in the follicular stimulating hormone, that is the 14
Okay, I'll come to all those points later.
Sir,
Now, what is the clinical importance of knowing about menopausal transition?
Sir, there is a clinical.
Why? Why you are so much worried about this?
Actually, sir, all the problems that occur during menopausal transition, that is menstrual irregularities, there may be cognitive difficulties, mood irritabilities, they all have overlapping. Like if we diagnose if it is due to menopausal transition, then we can really elevate the symptoms. So it is very important, instead of going through other somatic, we believe it's due to some other causes, and we don't realize that it is actually all these are due to the menopausal transition. So if we diagnose it, one thing, we can elevate his symptoms. The other thing, it carries a long-term risks. So we can prevent, if we recognize it, we can prevent those long-term risks too.
With
And you can
increasing
have some
longevity,
advantages. You can have some advantages of giving HRT prior to the age of.
Giving HRT prior will delay the menopause.
But most of you missed the first point. 1/3 of the life of the woman is the
because of the increasing longevity, the women are spending 40% of their lives in the post-menopause.
And most of the time, they're supposed to have some long-term symptomatic on one side and metabolic complication on the other side. That is to be kept in mind. That is
Menopausal
two
transition occurs in the age group where many chronic diseases or malignancies arises. So this is a very good opportunity for clinicians to detect these things also.
So, in the panelist, how many of you are going to accept menopause as a natural phenomena? Welcome menopause.
Yes, everyone.
Everyone.
Yeah.
And in the audience, I find all the stalwarts. Those who have become very famous. They have become very famous in the perimenopausal or postmenopausal age.
more than 7 days होगा उसका फिर 60 days
Now, someone has told about some staging system.
Yes, sir. Straw 10.
What is that?
Sir, straw
Human
10.
body has got stages. Every disease we are staging. Now, why not menopause? Why not premenopause?
So straw 10 is a standardized staging system for reproductive aging. It was given earlier in 2001. It was named as straw, but it was modified in 2011 and it was renamed as straw 10. It basically divides the phases of adult life into 3 major phases, that is reproductive, menopause transition and post-menopause. And it is further divided into 7 stages. That is, in reproductive age, we have phases from -4, -5, -4, -3B and -3A. Then in menopause transitional phase, there are -2, -1 and and in post-menopause, there are +1, A, B, C and +2.
Well, what are the criterias?
There are 2 types of
criteria. The big
criteria.
thing, if we keep on discussing, the whole time is would be over.
Yes, sir.
So what are the criterias
There are 2
to
types
put someone into the straw plus 10
Basically,
scenario?
there are 2 main criteria. There is the principal criteria, which is menstrual cycle,
Yeah.
and there is supportive criteria, in which there is one endocrine criteria, that is AMH, FSH, and inhibin, and the second one is antral follicle count.
Well, but there is another thing that is symptomatic.
That is
part.
symptomatic. Yes, sir.
You should have told me.
Yes, sir.
That is
vasomotor symptoms.
Vasomotor symptoms and your
Yes,
genital
menopausal
symptoms.
transition starts with hot flushes, vasomotor. During perimenopause, as the hormone level decreases, estrogen decreases, the patient feels hot flushes, irritability, and sometimes in obese patients, estrogen conversion, peripheral conversion is more. So heavy bleeding.
I'll come to that. Those questions are there. Don't get worried. If you say everything, then what I'm going to ask? Anyway, this is stages, early menopausal transition, stage 2-1. Then, what about some controversies? Do you think if this stage is plus 10 is perfectly all right?
Are there
What
any
about-
drawbacks? Any lacunae?
What are the
in it?
lacunae? Yeah.
It was applied only on healthy women.
So it is not included.
Comorbidities were not included.
Premature ovarian failure is not
Premature ovarian failure has been
Hysterectomy or
hysterectomy.
Surgical
Yeah, keep on saying there are 4 points.
Radiation and surgical menopause condition was not considered.
Polycystic ovarian disease.
Yeah, radiotherapy, chemotherapy.
Radiation and chemotherapy.
Yeah.
Gonadal
So all
dysgenesis.
these things are there. So lacunae are there. So many lacunae are there. We the clinicians, we are supposed to sort it out later. Now, do you know them? How do you like them? How many of you are looking your future in these pictures? Everyone. Okay, that's great. But somebody might become more gorgeous without so-called glamour. These are some of the examples. And you know also, everyone. So it is also possible. Now, again back to the bench. Endocrinology and anatomy at menopausal transition. What are the changes that do occur in HPV axis?
Initially, there is loss of ovarian follicular activity that leads to decrease in estrogen and inhibin concentration, which leads to negative feedback. So negative feedback to the brain or hypothalamus is decreased, and there is increase in GnRH secretion, which leads to increase in FSH and LH concentration.
Initially the follicles become less receptive to follicular stimulation. Because of that, there is less of inhibin production from the granulosa cells. As a result, the negative feedback of inhibin on
And
FSH
estrogen
is
also,
reduced.
and estrogen also.
Estrogen also.
The FHS starts rising.
So FSH starts rising, and as a result, initially in the early menopausal transition phase, more of follicles are recruited for ovulation. So initially there is no decrease in the level of estrogen, but as the reserves go on depleting, the estrogen level then starts going down, and as there is no ovulation, the progesterone level will decrease, and when progesterone level decreases, the pulse of GnRH is the negative pulse on GnRH pulse is not there. So again there is a rise of FHH as well as H, and that's it, I think so. And
before that, at the outset, follicles are getting resistant to gonadotropin.
yes, that I told you. Initially, first the
that is
follicles
the
become
basis.
resistant because of
and
that.
gradually the sequences occur. Okay?
Yes, that's true, sir.
And what about androgen, progesterone, AMH?
So androgens it is produced both by adrenals and the ovaries. So when we go to the menopausal transition phase, the adrenal production is still there, but the ovarian production decreases. So androgen decreases, but the sex hormone binding globulin increases. Sorry, it decreases. Because of that, the free androgen level may increase.
Because of the obesity increasing in the perimenopause,
that's
that conversion to testosterone will continue.
Sir, also the theca cells are spared, so ovarian androgen production continues. The theca cells are spared.
Yes.
Theca cells.
Mainly granulosa cells are affected, so AMH, inhibin and AMH both decrease because both are formed there.
And somebody was talking about obesity. Now, it's your turn.
Sir, in there is increase in the truncal obesity in the menopausal lady, so there will be conversion of the.
What benefit, what advantage, what disadvantage?
So disadvantage is there is conversion of the adipose in adipose tissue. There is conversion to the androgen
peripheral aromatization in the adipose tissue. The advantage is there is in prevention of osteoporosis. It helps in prevention of osteoporosis. And the disadvantage is that there is increased risk of breast cancer in obese women.
And diabetes mellitus, heart disease, everything is related to obesity. All metabolic syndromes.
There's visceral obesity basically when
central obesity.
Yeah, I'll come to that. But the advantage is that you said
osteoporosis. Helpful in osteoporosis.
And hot flush and other things. All menopausal symptoms.
Increase in hot flushes.
They are decreased.
And libido also increases.
What are the changes in the genital organs? Ovaries, fallopian tubes, uterus, vagina, vulva.
So slowly.
One by one. Come to ovaries and the fallopian tubes, then uterus, then vagina, vulva.
So in ovaries, the number of antral follicles reduce, and eventually the ovulation cycle is affected. The Graafian follicles, so ultimately the reduced levels of estrogen and progesterone, and the ovarian size. Definitely, it will start to
cortex
reduce.
decreases, increasing medullary complex.
And
what about cortex and medulla
cortex
ratio?
is thin, sir. Cortex is thin.
The vascularity and there will be the entire organ will undergo shrinkage. So like the cortical thickening will be there.
But
medullary components increase.
Okay. And then tube, fallopian tube, any change?
Atrophic changes are seen in fallopian tubes.
The muscularis decreases.
Loss of cilia is there.
You know everything.
Loss of cilia and muscularis decreases.
Uterus?
Uterus becomes smaller.
There will be atrophy of the myometrium and the endometrium.
And the ratio of what is to cervix reverts
the collagen tissue remains there, but the collagen tissue doesn't change for the uterus.
And about
bladder?
vagina,
Ratio
vulva?
is 1:1.
It reverts to 1:1.
So vaginal atrophy is there. The portio vaginalis is most affected. The fornices are lost. And there is
vaginal epithelium is thinned. There is
Narrowing
loss of
of the
vascularity,
introitus.
narrowing of introitus.
introitus is lost. There's loss of fat in the vulva.
Elasticity.
And about the pH, is any change in
The pH becomes more alkaline.
So there
More
are
than
increased risk of
4.5.
infections.
And the bladder, any change in the urethral lining?
Shrinking of urethral epithelium
Thinning
and
of
there
mucus
may
and
be
collagen
pouting
tissue
of
is
urethra
lost.
and urethral
The
carancles
transitional
can develop.
epithelium is dependent on the estrogen. That is
Estrogen,
why
yes.
it thins out, and there are more chances of
More
UTI.
chances of more infection, more
Infection.
urethritis, more irritation, and patient is not benefited by antibiotic course even. So they need estrogen local application or systemic as
I
required.
have not asked you the management. We are still in the anatomy, in the bench. Well, what about breast?
The breast tissue,
There will be loss of connective tissue in the brain.
fat will
And
increase.
thin-
It will be hanging breast like fat content will glandular tissue will decrease and the fat content will increase and there will be pendulous breast.
Skin and muscle?
Skin and muscles, skin will
Loss
be
of
lax
collagen
and
content.
wrinkling will be there.
Wrinkling of skin.
There is loss of collagen tissue. It leads to wrinkling of skin, and hair may become sparse. There may be balding, pubic and axillary hair
Fat
is
content
lost.
will increase.
Purse string and crowfoot appearance.
Loss of hair in
Around
the skin
mouth.
also. So because of the loss of tone, you have your uterovaginal prolapse also because of the menopausal status.
Stress incontinence can be there.
So these estrogen receptors are everywhere in the body, from brain to foot. So everything
Even in
might
the
be
brain,
affected.
even in the brain, the receptors are there, and that is why Alzheimer's is more
And
common.
cognitive
There will be
dysfunctions.
cognitive changes, there will be loss of memory and consciousness.
Okay. Let me pass on to other systems. Bone, cardiovascular system and CNS. Now, here is one statement. Osteopenia is the precursor of osteoporosis.
Yes, sir.
What are the meaning of these two terms?
Bone mineral density. Bone mineral density.
There is decreased bone
What is
mineral density.
osteopenia?
And what is osteoporosis?
Osteopenia and osteoporosis is defined on the basis of T score. We do a DEXA scan and when the T score...
I didn't ask how to do it. I just asked what do you mean by osteopenia?
Decrease in bone mineral density.
Osteopenia is decrease in the bone mineral
Mineralization
density
of the bone.
and osteoporosis,
osteoporosis
is severe deficiency.
They reduce bone mass as well in
The
osteoporosis.
trabecular bone is also fragile.
Osteopenia is gradual loss of bone
And
mass,
osteoporosis.
and osteoporosis is just the next phase.
Aggravation of osteoporosis.
Okay? So you talked about BMD. Perimenopausal women run the risk of fractures. Where?
Where? Vertebral column,
lumbar vertebral,
femoral
Police
neck and
fracture.
hands.
One, please. I can't hear anything.
It's lumbar vertebra, neck of femur, and the wrist.
And wrist. And what mechanism is involved?
It may be due to fall fracture, fragility fracture associated.
Actually,
Because
sir,
these bones has more trabecular bones and mineralization decreases after menopause. So these bones are more prone to fracture because long bones have more cortical bone like femur and ear. But femur, neck, vertebra, these all have more of
the mechanism is, sir, actually there's a receptor called rank which leads to which binds to the osteoclastic cells of the bone, and it leads to resorption of bone. And the estrogen is basically, it inhibits this binding of the rank. So when there is deficiency of estrogen, this binding is more, and so there is more of reabsorption, and so there's osteoclastic activity is more. The other is that in this stage there is decreased absorption of calcium from the gut, so that also leads to stimulation of vitamin D, which in turn stimulates PTH, which in turn again causes reabsorption of bone and osteoporosis risks.
Now somebody can teach me what is DEXA?
DEXA is dual energy X-ray absorptiometry. It is used to measure the bone marrow density.
And what about BMD? I don't know what it is.
It is the amount of minerals, that is calcium and other minerals, per unit area and volume of bone. It measures the strength of bone and it is interpreted as T score and Z score.
What is the normal value?
T score normally is plus 2.5 to minus 1 in normal. And in osteopenia, it is -1 to -2.5. And in osteoporosis, it decreases at or below -2.5.
Right.
And at the same time, you should look for calcium, urinary calcium.
Urinary calcium and creatinine ratio.
HDP and creatinine, I have already told. Now, what about cardiovascular system? What changes you are going to expect?
After estrogen is low, and after estrogen is low, there is high in low density lipoprotein, and that leads to. ये कौन सा आंसर आ गया? No. After menopause, LDL is high, so there are more risk of cardiovascular attacks and thromboembolism.
Triglycerides go up, and the
Triglyceride also go up.
The good type of cholesterol, HDL, goes down.
Bad cholesterol goes up.
And so there is vasoconstriction, atherosclerosis.
Yes.
All those things. I'll come to that, I'll show you picture. And what about central nervous system?
Central nervous system. There is brain fogging, aging of brain, shrinking of cortical material. So we forget things very fast.
What happens to the thermostat?
Thermoregulatory zone is narrowed.
That is when you have hot flashes.
That's the main thing.
That is hypothalamus dependent.
Hypothalamus where it is situated.
Thermoregulatory zone is narrowed.
Yeah. The thermoregulatory center
Setting point is lowered.
is imbalanced. And there is a change in the amount of neurotransmitter, particularly norepinephrine
Peptide, neurokinin and KND.
and we'll be coming to the drugs related to those two things. Okay? This is the cardiovascular mechanism of action of estrogen and progesterone in the cardiovascular system. I'm not going into detail. Now, who are going to have osteoporosis and fracture?
Who are the candidates?
Women who
who
are
more
having
prone for
sedentary
this?
lifestyle, or they are having early menopause, premature ovarian failure, obesity, high BMI, low calcium intake.
Have you heard? Fall risk factors. Somebody has the tendency to fall. Tendency to fall.
Patient taking steroid for long.
Yes. Smoking, alcohol, caffeine, all these things are being
Calcium and vitamin D deficient.
So
those on hypothyroidism. So you can assess the that is the fracture related risk when you calculate all these factors. So you have the FRAC score.
Yeah. And who are likely to have cardiovascular disease?
Cardiovascular disease, who are the people who are more prone to it?
Smokers, alcohol, obesity.
Now smoking in young girls, it has become very common. Girls smoke much more than men. So all of them are going to have these problems in future, isn't it?
A sedentary lifestyle, this has become very common. Everyone is on the chair all the time, especially the IT people. They don't have time to go out, so the vitamin D is also low. So these people are more prone to have fractures.
And one point is to be kept in mind regarding vitamin D and calcium. You'll have to take both. If you don't take vitamin, there is no use of taking calcium, because that will not be absorbed unless vitamin D is given along with this. Anyway, let me go to the clinics. What are the menopausal pattern prior to menopause? Menopausal transitions, yes.
Sir, initially the cycles will become more frequent as the menopause is being approached.
Not necessarily. Many people have oligomenorrhea before they stop finally.
Ma'am, like initially, like when the menopause is not set in, when it is in menopausal transition or just prior, that also has two parts, early and late.
Yes.
So in the early phase, because of the HPO axis being stimulated in a certain way, the FSH is increasing, and that leads to, in some of the cases it can lead to oligomenorrhea also, but in the frequency in those stages are they tend to increase. The frequency of menstrual cycle tends to increase because of that reason, and eventually when the estradiol fades away as the menopausal transition turns into the menopausal phase, then it turns into oligomenorrhea, and eventually the menopause sets in.
And if she starts bleeding or starts having malaria,
There may be irregular bleeding with
unopposed estrogen.
Because of the unopposed estrogen, they do
present
have a
with
tendency
heavy
of
bleeding also.
abnormal uterine bleeding, and they will have heavy menstrual bleeding, and
She may have endometrial hyperplasia, atypia, so we have to be very careful and follow her carefully. USG, endometrial thickness, endometrial sampling.
So whenever perimenopausal patient has irregular bleeding, don't ignore it. You have to do a endometrial biopsy and see for the endometrial thickness and TVS.
And we have to follow her.
Yeah.
So now, this is your question for which you are so long waiting. What symptoms are most troublesome?
Hot plus, vasomotor symptoms are most troublesome.
And why do they happen?
Due to peripheral vasodilatation,
Where the prostacyclin increases,
estrogen
and that
withdrawal,
is
sudden
peripheral
estrogen withdrawal.
And
the thermostat is
That's
altered.
called narrowing of thermoregulatory zone.
And also there is the excess of perspiration.
Sweating along with palpitations, there may be increase in pulse rate, there may be increase in blood pressure along with it, and it settles in within 5 to 7 minutes usually.
And here someone has talked about genitourinary symptoms. Why it occurs?
Because of the pH thinning of the vaginal
Take the mic,
epithelium,
I
and
can't hear.
the pH becomes alkaline, which makes it more prone for urinary tract infections, like frequency, urgency, and recurrent UTIs. Becomes alkaline.
Vaginal dryness is also one of the
Estrogen
symptoms which
receptors
they
are all over the body.
Moisture of vagina
And because of lack of estrogen, the glands are not very active. They are not secreting many.
The dorsal bacilli and the vaginal flora decreases. The dorsal bacilli is decreased.
What about psychological changes?
The mood swings.
Mood swings are
They
there.
occur
Low
at-
mood.
Mood swings,
Anxiety,
depression,
irritability.
sleep disturbances, anxiety. She feels low that I am not like I was 10 years ago.
The emptiness syndrome. The emptiness syndrome, because at that time all the children are out.
Yeah, they are free. Yeah.
Yes, loss of concentration is
Loss
there,
of
yes.
concentration. There is no
And
immediate
insomnia.
goal. But now the situation has changed. The women after 50 doing a lot of things, and they have new goals in their life. I have read some Ushian score, so we can calculate and ask questions. If the score is more than 50, she is doing good, and she will be benefited with our assistance in a better way.
Yes, that is a good way to tackle the scenario. Sexual dysfunction, can you highlight?
Yes, because of the vaginal dryness, and the glands undergo atrophy, and there is loss of libido because of the hormonal changes and disbalance, and the vaginal mucosa undergoes atrophic changes, and this
The
leads to
dyspareunia may be
dyspareunia,
there.
and
There is shortening of the introitus, there may be dysporenia due to that also.
Yes.
And somebody have talked about skin and hair. Due to loss of collagen, this
Purse
around the
string
mouth,
and crow
purse
feet.
string.
Crow feet.
And
The crow feet. This.
That's it.
Yes.
Change in voice.
Pigmentation and
Change
loss
in
of
voice.
collagen wrinkles.
And there is one condition called hyposexual disease dysfunction.
Testosterone is
These
low.
are the basic symptoms which you have talked about in menopause, and I'm not going into details in this sexual desire. Now comes the management. Can you prevent menopause?
No.
No.
No. Menopause is as natural as menarche, and it has to be embraced with care, with concern, and with cooperation with of the clinician, of the family, and initiative by the patient herself.
The question is, you cannot. Can you prevent? No. Answer is no. Bas. Just stick to it. Is there any role of non-hormonal therapy to support menstrual transition?
Yes. Those are called complementary alternative techniques that include cooler environment, lifestyle modification, diet, yoga, and some
Calcium and vitamin D supplementation.
isoflavones, vitamin E, soya products, black cohosh, cessation of smoking and alcohol.
Isoflavones, they have estrogenic effect.
Yes, ma'am.
So that is not absolutely non-hormonal.
And smoking and alcohol. Don't miss it out. It's very important, very common. But
in our area, sir. In our area.
But we are coming from other states.
It's very common here too. The next generation, very common here. Gen Z generation.
Now, can you tell me something about non-sex steroid drugs? Yes, very good. Come up.
You can give SNRIs, SSRIs, clonidine.
Yes.
Main problem is with giving estrogen, Premarin and all is increased incidence of breast cancer.
My question is quite different.
Okay, so we have to refrain from giving estrogen, and we have to search alternatives. So we can give isoflavones, most commonly being used, and others are SOMs. Bisphosphonate is for proved osteoporosis in late stage.
Venlafaxine.
Yeah. Tibolone is good for a hypoactive sexual desire disorder because it helps in mood elevation and all. Soy proteins, that is same as phytoestrogens, and vitamin E should be given, and she should keep herself busy. Gabapentin is also helpful in hot flushes, but some women feel giddiness.
Which SERM would you like to give? Which SERM would you like to give?
Raloxifene, Bazidoxifene, along with conjugated equine estrogen.
How many of them have got impact on menstrual symptoms? You have mentioned most of the drugs, all of them are written over here. How many of them have got impact on menstrual transition symptoms?
SERMs, selective estrogen receptor modulators, and estrogen therapy, systemic estrogen therapy.
None of them. None of them, sure.
None of these are going to cause postmenopausal bleeding.
Phytoestrogen may have, but
Menstrual transition symptoms.
All of them will help. All of them will help.
All of them help.
Yes, in relieving their agony.
Bisphosphonates will not help. Bisphosphonates will not help.
So the panelists have been divided into two groups. Who are in favor?
bisphosphonate increase the vasomotor symptoms.
Which one?
Calcitonin.
There are 10 points. Out of them, which causes improvement, which causes no effect. Clear cut.
SERMs. अरे वैसोमोटर सिम्टम बढ़ जाता है हाँ तो खराब हुआ ना बिस्फॉस्फोनेट से ना
Bisphosphonates and calcitonin is for bone. It's not for the vasomotor symptoms.
Menstrual
We are giving it for osteoporosis.
Now check it. Check your answers. biphosphonate calcium, vitamin D, raloxifene. They have got no effect on menstrual transition, menopausal transition symptoms. In contrast, clonidine, gabapentin, SSRI, phytoestrogen, soy proteins, and a new drugs that is newly come up in the market, Vesoza, they have got impact on improvement of menopausal symptoms. Okay. Now the favorite one, the hormone therapy, the key therapy, indications of hormone therapy. What are the indications?
The vasomotor symptoms we can give. For premature ovarian insufficiency we can give, and for osteoporosis we can give. Yeah, premature ovarian failure. That is natural. Yeah. For after surgical menopause also we have to give till the age of 50, which is natural menopause.
What about premature ovarian failure?
In that also we have to give. It is recommended to prevent cardiovascular complications.
Uterus is there, so we have to supplement medroxy in last 14 days.
I will come to that. Wait. But you have not mentioned the quality of life.
Yes. It improves the quality of life.
So what are the benefits?
The vasomotor symptoms and urogenital atrophy symptoms decrease. It's also cardioprotective and increases the bone mineral density and also prevents against colorectal cancers. And improves the quality of life.
Then comes the favorite question. What are the hormones used?
Estrogen, progesterone, combined estrogen and progesterone. Then androgens, which include testosterone and DHEA, tibolone and SERMs.
Can you use all of them in all the situations?
No, ma'am. We have to individualize
them depending on what comorbidities the patient has. Breast carcinoma patient, or she's been on chemotherapy, or she has endometrial carcinoma, ectopia.
Do you think there is a necessity for pre-therapy assessment and monitoring?
Yes, sir. Yes, sir.
Two terms are there: assessment and monitoring.
Yes.
Do you think
both are necessary?
Both are necessary.
Both are necessary.
Now tell what type of assessment you want to do. Come on.
First, we will take a proper history. We will ask about the age of menopause, and we will ask about any abnormal discharge, any abnormal vaginal bleeding. Then we will perform a physical examination, which includes a pelvic examination also, per speculum and per vaginal examination. We will perform a pap smear. We will perform a transvaginal ultrasonography, and then we will go for breast examination and mammography.
Ma'am, most basic is pap smear, one ultrasound and one mammography.
DVS especially for endometrial thickness.
And mammography.
At this age you have to do that.
We have to do this
and
blood sugar level.
What is the cutoff in menopausal patients for endometrial thickness?
4 mm.
More than 5 is bad.
Less than 5.
4.
It can go up to 7 mm also if she's not bleeding, if she's not having bleeding.
So you know everything. But one point you have not mentioned. You must counsel the patient, and that is very important. Thorough counseling. Okay? What are the risks of HT? I am not going to all these things you know. What are the contraindications? You also know. Now, estrogen therapy. What are the various routes? Quickly.
Oral transdermal, local cream, transdermal,
subdermal, vaginal gel is there, transdermal patch is there, vaginal ring is there, and nasal spray is there.
Is there any role of progestin?
Yes, sir.
How?
And in cases of atypia, in case of endometrial hyperplasia with atypia, you're not going to give estrogen.
Now this is your question, madam.
So what are the situations? How do you manage them? Like question 1 is management of menopausal syndrome in hysterectomized and non-hysterectomized patients.
Because I have been given only 5 minutes.
In hysterectomized patients, we can go for only estrogen therapy, ma'am.
Right.
And in non-hysterectomized, it is after the assessment we can go for combined.
You have to, if she's not hysterectomized, then you have to give progesterone along with estrogen.
Estrogen, yes, sir.
And if the patient has had a history of VTE in the past,
then ma'am, only estrogen we will prefer. We will not.
she has a history of VTE.
Then
We don't have to give HRT then.
Only dermal patches can be given. Oral we will not give.
And
non-oral.
Pardon? Yes, you can give non-hormonal, can give venlafaxine. And if the patient has had endometriosis, she's had THBSO for that. Now she's having hot flushes. Yes, you can give Tibolone.
Usually in patients of endometriosis, even after menopause, the estrogen levels are not low.
And if you give combined, yes.
Yeah, we have to see what her estrogen level is, and then only we will decide.
Skip this question because it's a very
controversial question.
Controversial, yes.
Now, case of
Not
cancer
for
cervix, who has undergone radiotherapy and has VMS, will you like to give HRT? She has hot flushes.
Oh no, I will not. I will give clonidine, etc.
See, there are studies which have different opinions.
Why not? Why estrogen? Is there any bad effect of estrogen?
Give estrogen because
history of
cancer
history-
cervix is
we
not
can
thought to
give
be
HRT
hormonally
in this case.
mediated.
Only there's some studies show there's a mild increase in the risk of adenocarcinoma, but not of squamous cell carcinoma.
Ma'am, that adenocarcinoma, if happens, is also very traumatic.
That
But
is
there's
okay, but
no-
the studies
not
are very
much risk.
limited and the evidence is low. Okay, now a patient who has had breast carcinoma and she has developed the VMS symptoms, she needs HRT.
Some isoflavones we can give. We cannot give estrogen.
Yes,
We cannot
SSRI. You can give the SSRI. You don't give contraceptive pills, or you do not give any hormone therapy for that.
Because breast carcinoma patients after surgery, if it was E2 dependent, then they are already taking tamoxifen, and that causes a lots of hot flashes. So
Yes.
we can give her isoflavones, phytoestrogens, etc.
No, isoflavones again they act on the estrogen receptors,
Yeah.
so we cannot give them offhandedly.
Clonidine we can give, ma'am. Clonidine.
Yes, SRI you can give.
Yeah.
Now, perimenopausal patients with diabetes mellitus and having menopausal symptoms. She's a diabetic patient.
Yeah.
And she
She
has
is already
VMS.
carrying a risk of endometrial carcinoma, so I am not giving her estrogen.
No, if she's controlled diabetic, you can give it, but of course you have to monitor her.
Monitor.
With the
And here patients are not available for monitoring.
Yes,
they get lost.
All these questions are very tricky questions. You
Yes.
have to judge every patient
Yes, every
according to its
patient.
merit.
According
That's
to
the reason those have been placed.
Yeah, because they are if they are educated, they will understand our language.
Okay.
Otherwise, they will not turn up.
Tibolone, is there any side effect? Can you tell one or two side effects?
That does increase the risk of breast carcinoma?
With tibolone?
No.
I don't know.
So it causes tenderness but not breast carcinoma.
Yeah.
Is there any role of non-medical support in the form of spouse, family, children, relatives, work?
Sir, she has to keep herself engaged is most important. She should make friends. She should go around, walk around, and she should try to live a happy life. Because we are having long life after menopause, even in
Much
India.
more important than drugs, than to listen from your friends, this will going to happen, this is the bad effects of menopause, doctor has given you this hormone, your life will be hell.
So what is more, the thing that these aged patients want is a time from you, a little bit of time and a patient listening. That's the most important thing that you can give these patients. Thank you all for a patient cooperation.
Thank you, ma'am. Thank you, sir.
How many of you loved them? Have you seen?
From Bengal.
Now menopause make for a newer trends, new thought, and that is cosmetic surgery. What is its role? Very quick. All of them has, have gone through this cosmetic surgery. That's the reason I placed him. Yeah, all of them, all of them.
Hello. Facelifting surgery is most common. Botox injection, facelifting. Now this क्या कहते हैं वो vaginal tightening with laser beam probes.
Labioplasty, vaginoplasty.
Yeah. Aesthetic gynecology is already up in the market.
Yes,
now.
yes. Especially
lip surgery.
Yeah, especially in urinary incontinence and this vaginal laxity, they are getting this done with a laser probe, cosmetic vaginal surgery.
Very recently, one of my cosmetic surgeon friend told me that she is doing pubic hair transplantation.
My pubic hair transplantation. This is too much.
But it is going to happen in future. So goodbye estrogen. Agree or not? Can you go without estrogen with all these cosmetic surgeries?
No.
No.
We
That
need
is the
help.
answer.
Yeah.
Accept it. Happily.
And everybody wants to be like this after 65, 70, 75, 80 and on. And postmenopausal endometriosis, it is a big area. I am not going to deal it. So let's say goodbye. Goodbye to menopause and its symptoms. And thank you everyone for patiently listening.
Thank you.
And
Thank
the
you, sir.
panelists
Thank you,
for
sir.
teaching
Thank
us
you, sir.
so many things. Thank you.
Thank you, sir and madam. Many of our members are in that transition phase of menopause, so they must have benefited from this discussion. Yes, yes, sir. और शकुंतला मैडम को भी बुलाना। ठीक है। जाइए जाइए। मैम आइए ना। हाँ अभी पहले फोटो खिंचाएगा पहले हाँ बुला रहे हैं
कॉर्नर वाला छूट गया
नहीं रुको ना रजनी दी जाइए हाँ तुम लोग बोल ठीक है मैम सर और मैडम के मैम आप मैडम को कर दीजिए ना हाँ फोटो लीजिए फोटो लीजिए हाँ शकुंतला मैडम को बुलाने बोलिए हाँ मैडम शकुंतला मैडम प्लीज हाँ सर को आप दे दीजिएगा ठीक है रुक जाइएगा मैडम अभी पहले फोटो हाँ